especially for all of you who were so good at being so timely. So yay. I am Katie Stokes. I am one of the co-chairs of Community Board 4's Social and Racial Justice Task Force. And we first spoke on our task force a couple of months ago about how important it would be for us as a community board to address the issues of health disparities in the Black and Latinx communities, and specifically how it pertains to some of the biggest issues of our day, most notably maternal mortality, and right now, especially COVID and the COVID vaccine. But just for those of you who are new to community board meetings, I just want to give a couple quick overviews. So our meeting is public. It is being recorded this evening, and it's also being live streamed on YouTube. It will be available after we're done here as a recording, and you can go to our website to see it. We have several speakers this evening, and then we have people of the public who have joined us, and welcome to all of you. And we will be encouraging you to submit questions. Our chat function is disabled this evening, so you will submit questions through the Q&A, or the question, it's Q&A function on Zoom. Let's think.
Katie, are you gonna also at the end, if people do raise their hands, because I already have one person raising their hand in the attendees, will you take that as well?
Yes, we will take that later as well. Yep.
People can raise their blue hands, their virtual hands under the participation section if you're an attendee.
Yeah, so please feel free to raise your hands too. We're not actually going to get to the Q&A section probably for about 45 minutes or an hour, because first we're going to allow all of our speakers to speak and address us. So just to let you know, if you are raising your hand, we won't be calling on you for a little while. But I also want to let you know, so our community board has about 50 members on it. We have several committees. We have, including also our task force, but then there's also the, oh, Maria, correct me if I'm wrong here. So it's Health, HHHC. I even serve on the subcommittee, and I don't remember what it all stands for. Tell me what it is, Maria.
You mean Housing, Health, and Human Services?
There you go.
Okay.
So they are also participating this evening, and it was with their help that we put this panel together. So I just wanted to give them a shout out. And now I'm going to turn it over to Leslie Williams, who is on both the task force and HHHC. And he will
triple HS, excuse me, triple HS.
Gracious, see, I'm getting it all wrong now. And he will introduce sort of what our goals are this evening and a little bit about this forum. So Leslie, over to you.
Thank you, Katie. Our goals for the forum basically is to acknowledge the existence and profound impact of disparities in healthcare on Black and Indigenous people of color in New York City and our district, to address vaccine hesitancy and access issues for Black and Indigenous people of color, to explain why the development of testing protocols for COVID vaccine is different than past vaccines for Black and Indigenous people of color, and also to identify resources to help Black and Indigenous people of color to access the COVID vaccine, and to listen to community and poll results and identify any follow-up with city and/or electeds that can be done by the task force. By doing so, we will reach out in writing. We would contact our local electeds. We would advocate with service providers, with city agencies, and the like. Now, I'd like to introduce you to our chair of the Housing, Health, and Human Services Committee, Maria Ortiz.
Hi, good evening, everyone. Thanks for being here tonight. So Maria Ortiz, co-chair of Housing, Health, and Human Services. And I have helped Viren and Katie put this together along with Leslie. And I'm just going to be introducing the speakers one at a time. And first, Dr. Fullilove, I believe you also have to teach a class at 7:30.
Correct.
Correct? Correct. Okay, so we are going to move along to you first. We were going to have Dr. Jessica Shepard speak, who is an OBGYN. She's also not here right now, but we'll have you speak next. And the goal is to have each speaker present for maybe 5 or 6 minutes, leaving space for questions and to have a conversation, and questions from the public as well as among us. And Dr. Fullilove, I apologize. Oh, I see Dr. Shepard coming on, but Dr. Shepard, is it okay? I'm going to let Dr. Fullilove speak first because he has to leave a little bit early. All of you are incredible people, I have to say, because I'm the one who has to read the bios. I have to tell you all, I did edit and shorten the bios, okay? But you're all incredible and wonderful people. For those of you who are listening in, you can Google these folks and see all the experience they have and how accomplished they are. Dr. Robert E. Fullilove has authored numerous articles in the area of minority health. From 1995 to 2001, he served on the Board of Health, Promotion, and Disease Prevention at the Institute of Medicine at the National Academy of Sciences. In 2003, he was designated as a National Associate of the National Academies of Science. And since 2010, he has been teaching public health courses in 6 New York State prisons that are part of the Bard College Prison Initiative, which I think is awesome, and serves as the senior advisor to BPI's public health program. Dr. Fullilove serves on the editorial boards of the Journals of Sexually Transmitted Diseases and the Journal of Public Health Policy. He has been awarded the Distinguished Teaching Award at the Mailman School of Public Health at Columbia 3 times. Dr. Fullilove, if there's anything that you think is really pertinent to add from your bio that I took out, you're welcome to add it. Thank you for being here.
Glad to be here. So I understand that folk are interested in what for us in public health is quite a monumental task. We're trying to figure out why race and ethnicity have such a big impact on things like life expectancy. Why is it that folk of color, particularly in poor communities of color, can often have lives that are likely to be characterized by exposure to disease and the likelihood that reaching the age of 65 will be something of a challenge? Nowhere has this been more apparent than with COVID-19, when nationally, when you look at the numbers, who's been impacted by this pandemic, it becomes very clear that communities of color are not only hard hit, they suffer the highest rates of hospitalization, and in many instances, they have the highest rates of mortality. This gives us the sense that somehow or other, being a member of a racial or ethnic group somehow means that you've inherited through your genes something that means that you're much more likely to become ill, and if ill, are much more likely to wind up in the hospital and maybe much more likely to die. Those of us who do this work are very clear, however, that whatever else might be true of race, in the United States, it is much more likely to basically be a descriptor of something that says a great deal about what your social position and your social status will be. If you were to ask a geneticist, what are the factors that basically divide members of one race from another, you'd quickly discover that the differences are so minor that it is hard to map being someone who is afflicted by a particular disease condition onto membership in a particular racial or ethnic group. In other words, they just don't go together. We're much more likely to be looking at things that are socially determined, not biologically determined. In fact, there's an entire field of public health and medicine that looks at what are described as social determinants of health. And the most important of these determinants happens to be where you live. Despite the fact that we sometimes think with the election of Barack Obama that we live in a post-racialized society, certainly the events of last spring with the murder of Michael Floyd have really led us to believe something very different altogether. We're really kind of sure that more than anything else, of all the factors that are likely to impact your health, living in a particular neighborhood and being exposed to the factors that are present in that community are much more likely to have an impact on your health than whether or not you're brown-skinned, blue-eyed, or have straight yellow hair. What we're saying more than anything else is that it's where you live and the exposures that are present in the places that you reside in that are much more determining for who is going to live a long life and who is not. Nowhere is this more evident than if you look at maps of health in the city of New York, where you'll suddenly discover that the difference in life expectancy between folks who live in the poorest zip codes and the ones who live in the richest zip codes is often as great as 10 years, a whole decade of life associated with where you work, where you grow up, what kinds of exposures you have as a result of being in your social and physical environment. And we're more and more evident that what we're living with is a situation in which race decides so much of where you're going to live, what kind of job you're going to have, what your educational opportunities are, and unfortunately, the likelihood that you'll do time in a jail or a prison. That it's the social experiences, the social determinants of health that are associated with race and ethnicity and the segregated communities in which we live that are probably most determinant in figuring out what your health status is likely to be. So when we study social determinants of health, we look to see why COVID-19 is not only associated with people in a particular race or ethnic group, we're also interested in how much where your zip code happens to be will often determine how many people are infected with COVID-19, how many people are hospitalized, and how many folk are suffering from really severe illness. That there's something about where you live, something about where you work, something about the nature of whether or not, with respect to this virus, you're in a setting where you're with people, exposed to people, perhaps through the conditions of your work. Those things seem to have so much more impact on whether or not you're infected and whether or not you will struggle with COVID-19, that we're very, very clear that the way to begin to understand health disparities is not to look at what is happening with someone's race or ethnicity, but rather to look at what we like to describe as structural racism, which very simply really describes how much in a society like our own, questions of membership in a racial group or an ethnic group will determine life outcomes, will determine the quality of education you get, will determine where you're likely to live, will determine something not only of your job, but the salary that you're likely to get. If these things are all somehow also structured by where you live, being in a formerly red line community means that the quality of the public schooling you got was so much lower than it should have been. We're very clear that one of the ways in which you combat the social determinants of health is to not work on conditions that are associated with your racial group, but to work on conditions that are very much associated with your work environment and your residential environment. If it's possible to change the conditions under which you live, if it's possible to change the nature of the exposures that are associated with where you happen to reside, we believe that that will have a dramatic impact on health. And it's one of the reasons why so much of what we're doing with public health and the social determinants of health looks at the conditions of segregated America and tries to understand how much of it, especially in COVID-19, has a great deal to do with where you live rather than who you are. How about I stop there?
That was great. Oh, can you hear me? Oh, okay. I am unmuted. That was good. Thank you. And I am writing down some questions that I will have for you all. That was a good place to stop. And we are going to move to Dr. Shepard, Dr. Jessica Shepard.
Hi, how are you?
Hi, thank you for being here, Dr. Shepard. I also, you have a wonderful bio. I cut it down a lot.
Please.
So Dr. Shepard is an OBGYN and women's health expert and also the founder of Her Viewpoint, an online women's health forum that focuses on addressing taboo topics in a comfortable setting. As an OBGYN, she practices at the University of Illinois at Chicago and also serves as the director of minimally invasive gynecology. Dr. Shepard has written in various journals, including
A lot
magazines such as Women's Day, Women's Health, Parents, Essence, WebMD.
Yep.
She is also seen regularly as an expert on the Today Show, Dr. Oz, Steve Harvey, CBS News, Fox News, and radio programs nationwide. She serves on the board of the Multicultural Leadership Committee of the American Heart Association and also the Women's Health Foundation. Thank you, Dr. Shepard, for being here.
Absolutely. Thank you for having me. I was jumping on actually from another forum that was going on with Congresswoman Yvette Clarke and them pushing a bill that just went through on Friday regarding fibroids and disparities and what we can do in order to bring more awareness to women's health, specifically with fibroids. But that really, is a great transition into what we're discussing tonight, specifically with racial health disparities. And really what we're seeing, I recently became the chief medical officer of Very Well Health. And so in that role, what we're trying to accomplish is a resource center in order for us to bring more awareness to these disproportionate burdens that are on the African-American community and how we can actually put more research into it, allow for people to be more aware of exactly just how that's impacting our communities. Of recent, I think it was early this year or late last year, there was finally that the public health, they're saying that racism is a public health issue and actually recognizing it as a health disparity and bringing a name to it. Rather than us just skirting around the issue. And this is where we'll start to see some impact even in health organization, from a hospital setting, health insurance coverage issues. If we can call it by what it is, then we can really bring it to the table in the forefront in order to get the disparities recognized. And when it comes to disease state conditions, making sure that we have the appropriate requirements that are needed. Like you saw in COVID, yes, we were more likely to have worse outcomes and a higher likelihood of dying. But a lot of that had to do with things that came out in research throughout the last year, how a pulse oximeter measures oxygen in someone of color versus someone not. And that's why there were many cases that were missed because it was not reading the oxygenation properly, and therefore people weren't being seen as severe or critical as they were when they needed to be attended to much differently. And so, the racial disparities that are associated with COVID-19 should not really be used to propagate any myths related to racial biology. What it really should stand for is that there is a need, and there needs to be a demand to meet that need. And we need to be ready to rise to the occasion, whether that comes through patient advocacy, education, how we train our physicians, and allow for them to see that implicit bias that comes even when walking into a room and seeing someone of color, and bringing associations before you even meet that person. That has a lot to do with how patients are treated and the care that they will get. And then even coming from an organizational perspective, being now in a leadership role, an executive leadership role, that's where a lot of decision making occurs as well. And if we're able to see more people that look like me in these positions, then we can make impact, and we have that ability to halt any negative impact or stop any cultural bias or ethnic bias that is propagated from top down. And, that's my mission, is to not only be very vocal about disparities, but actually putting action to my words and using some influence in the positions that I can. So I hope that we have lots of questions regarding whether it's women's health or even outside of women's health today that I'm able to answer. So again, I'm very delighted to be here, and thank you for allowing me to be on this platform.
Thank you so much, Dr. Shepard. Happy to have you here. And next, we're gonna let Marlene Taylor speak. Marlene is a physician's assistant, AKA primary care provider, with over 30 years of experience working in the field of HIV and hepatitis. She is currently the assistant director of HIV and addiction services, as well as the family medicine provider at Ryan Chelsea Clinton Clinic, which is right here in our backyard. Prior to Ryan, she was appointed to the staff of the infectious disease clinic at Montefiore Medical Center, where she treated over 300 patients who had followed her for over 15 years. That rumor is true. Marlene was on staff at the Special Services Clinic at North General Hospital in Central Harlem from the late 1990s until the hospital closed in 2010. Hi, Marlene.
Hi, thank you.
Thanks for being here.
Thank you so much. Good evening, everyone. And I want to thank the Social and Racial Justice Task Force of Community Manhattan's Community Board 4 for allowing me to speak with for the community as well as with the distinguished panel who are here this evening. As a primary care provider with over 35 years, working primarily in AIDS and other infectious diseases in communities of color, mainly in Harlem and the Bronx, it's just important that we acknowledge that COVID has not only highlighted what we have already known historically to exist, but it really has shown the inequities in a way that we could have never imagined, not those of us in healthcare. It's been quoted that it's actually exposed the great divide, not only locally, but nationally and globally. This evening, my role as a clinician, and I'll just show a few slides from our Ryan Center. We had a town hall meeting, which really spoke to the vaccine and some facts around COVID. But my role is hopefully to be a resource for the community and to answer any questions that you may have around the vaccines, COVID, and of course, other diseases which impact communities of color. So I'm not sure if the slides are in the share box, if there's, Jesse.
Give me 1 second, Marlene.
Okay.
Nope, that is not the right one, right? That's the other one.
Yes, that's it.
This is it. Okay.
So you can go to the next slide. Actually, it's the other, it's
That's
the first
right.
one that you had. The first one that you had up.
Okay.
I
hold
think
up
you
one
had
second.
the first.
Give me 1 moment. I apologize.
It's okay.
Technical difficulties are what we live with every day, all day now.
It's true.
And speaking of technical difficulties, if I'm having some issues with internet, I see. So if Leslie, Vera, and Katie, I shared the bios with you in case you need it and need to continue, as well as some of the questions.
There we go.
Okay, great. So the next slide. Okay, next slide. So Ryan Health is dedicated to providing high quality, affordable, comprehensive, linguistically appropriate, and culturally competent healthcare services to medically underserved populations. All patients are treated equally with dignity, respect, courtesy, confidentiality, and concern for safety. The organization's mission is guided by the founding principle that healthcare is a right, not a privilege. Next. Oh, so as I mentioned, you can go to the previous slide, that COVID-19, the pandemic showed all of the inequalities that have always existed, as we know. Next. So what I'm just going to highlight in the next few slides is the vaccine, which we received first, the Moderna vaccine. And this is what we have been offering patients in the community to receive. And just a little bit about the clinical trials. They used 89 clinical sites. There were almost 40,000 patients enrolled in the trial. The distribution was about 63% white, 20% Hispanic, 10% African American, 4% Asian, and 3% others. Important to note that although we represent as African Americans, I have probably, 50% of my patients or more African American who I've had for years. And their question is always around how many patients of color have been participants in the trial. And I mentioned that, the fact that we represent approximately 13% of the US population, and that we were able to really see at least 10% of participants in the Moderna trial. Historically, about 6% of African Americans participate on average in trials. So to see a number like 10% was important to mention to them. The age distribution was what we see in our clinic. 64% approximately were over 45, 39% were between 45 and 64, and 25% were 65 and older. Next. So when you look at the racial and ethnicity distribution, again, as I mentioned, the fact that 63% were white, 20% Latino, 10% African American, 4%. So the pie diagram really shows the demographics in a way that when you look at the phase 3 trials for Moderna, you can really see a good representation, which mirrors that of the US population. Next. And when we look at who participated in these trials, we can see an array of diversity. 50% male participants. We saw educators and students. As I mentioned, around the African American population. We saw people who worked in retail, restaurant, and hospitality. We saw a good representation of females, as well as healthcare workers, of course. Next. So many of my patients ask about how does this vaccine work? And I show them as concise as possible that the messenger RNA, it's a messenger RNA vaccine, and that the genetic material that teaches the cells to pick up a spike protein on the outside of the virus is what is the main mechanism, that the messenger RNA material from the vaccine is then destroyed and disintegrates. A lot of the misconceptions around does it go into the DNA and change our genetic material is something that I really try to make sure that they understand and actually show them the next picture. Next slide.
Oh.
If you can go to the next slide. Yeah.
Sorry.
That's okay. And try to show them that the antibodies after that protect them from COVID-19. So I show them that the way that the vaccine actually is able to make antibodies is that it works by attaching to like this lipid nanoparticles, and then it actually is in the cytoplasm, not in the nucleus, and makes these and stimulates an immune response that allows for antibody production to protect them from the vaccine, from the virus. So actually show them, because a lot of, as I mentioned, misconceptions around the vaccine changing our genetic material. Mm-hmm. Next. And so, again, that the vaccine does not affect our DNA, that the messenger RNA from the vaccine does not enter into the nucleus, that it's impossible for the messenger RNA to give someone COVID. And a lot of times there are questions around, well, I got sick from the regular flu shot. I'm probably going to get sick from this, and making sure that they understand that that actually shows that they have competent immune systems, and that they're actually showing us that they're able to develop antibodies and to actually, that they have stable immune systems, and that the technology is not brand new. And then we forward this YouTube video, which of course we're not going to show tonight, but that's a really detailed video which really shows how messenger RNA vaccines and others work. Next. And why was it developed so quickly? So, the idea around, well, they did this so quickly, why should I be part of it? I'm going to wait. And just to, make sure that they understand that the reason the manufacturing started early and it's still underway while we're developing data is that they understand that it didn't begin right away, that they were familiar with this technology. However, we wanted to produce these vaccines quicker because of the mortality associated with COVID, and that the FDA and CDC accelerated the process by prioritizing the review and authorization and ultimately the recommendation of these COVID vaccines. Next. And, you know, again, mentioning that those side effects that people may develop are reactogenic, which is a good thing. And as I mentioned, that their immune system is working, that there were no noted in the trials, no serious side effects, and that they would develop, you know, I mean, a good percentage of patients may develop some tenderness at the site. The pain and low-grade fever and fatigue usually resolves within 1 to 2 days. That 80 to 100% of patients, as I mentioned, had this on, you know, injection site discomfort and pain, but that resolves with compresses and in some cases, you know, recommending Tylenol. That 25 to 50% reported fatigue after dose number 1 and a little higher in those after receiving dose number 2. That 4 to 10% repeats of, you know, reported severe enough fatigue to miss 1 day of work. And at Ryan, the fact that at least 75% of our employees have already been vaccinated, we've seen this, and most of the staff have been able to come to work without any complications. Next. And next slide. We talked about that. And, you know, the differences among the different vaccines that, you know, storing, having to do also with, for example, a question that comes up is what is the difference between Moderna and Pfizer? And with Moderna, it's a 28-day between the first and second dose. With Pfizer, it's 3 weeks. You know, these are just some details which have to do with the time of puncturing the actual vial, how many doses are in a vial, that you can't really return it. That's why we really try to make sure that we have people. And at this point, compared to when we first started offering the vaccine until now, we've actually have people waiting. And before, you know, it was by appointment, and we still have that. And Charlene, my coworker, will go into detail around the policies that are in place at Ryan. But it's interesting to see that it's becoming more and more just the differences around the patient population and how they show up for the vaccine. Next.
Marlene, are you close to
Okay.
the last slide?
Yeah. I'm
Okay,
sorry.
great.
Yeah.
Are you
Okay.
close to the
That
last
slide? Then
Okay.
let's slide really quickly. I think.
Thank you.
I think that's it. Yeah. I think that's it. Yeah. We'll talk again. Charlene will go more into this about what we're doing at Ryan.
And I did write some questions that I have for you.
Okay. Great. Okay. Thank you.
So our next speaker, Sandra, is everything working well for you? Are you on? I'm not sure.
Let me unmute myself. Can you hear me?
I can hear you. I don't know if you'll be able to show your video or not, but let me just give your.
I'm gonna make an attempt here. Give me a second.
Okay. I will explain who you are for folks who are listening in and watching. So Sandra Morales is also someone I would say from our backyard, has been a registered nurse for over 30 years. Her experience in nursing includes women's health, obstetrics, of which she's very passionate about, and she's a certified childbirth educator. Sandra's an elected member of the RN Council. She's currently working at Mount Sinai Union Square, providing patients and staff COVID testing, vaccinations, and education. Sandra has had multiple roles during this pandemic, which included as a surveillance nurse with infectious disease and safety at Mount Sinai Beth Israel. On a more personal note, Sandra's passion for advocacy and healthcare are fueled by her 87-year-old mother, who has Alzheimer's disease and is a human rights advocate and still offers to march in Washington. Sandra wanted me to add that today her mother is COVID-free, vaccinated, and continues to be the wind beneath Sandra's wings. I thought that was beautiful, so I had to add it. I just want to remind everybody also, keep it a little bit brief, 5 or 6 minutes, that we want to be able to ask lots of questions and have a discussion. Thank you so much, Sandra, for being here.
Thank you for inviting me. Well, I'm so glad to be able to participate in this forum discussing community care. I've lived on most of my life on the Lower East Side. My mom has been here since she came in here when she was 16 years old, lived in Central Park West, moved from there, came to the Lower East Side, remained here. And here's where I became a nurse, educated, and I've worked at Beth Israel, now Mount Sinai Beth Israel, for over 30 years, 32 years to be exact. During that time, I've had opportunity to work in obstetrics, which is absolutely my passion. Forgive the clouds behind me, but that's what we would see in our for. Just to get the mothers in the right mood. I thought it would be appropriate for my discussion, but what I was asked to kind of bring to the table today was my personal experience as a registered nurse, caring for our clients in this community, our patients, and how the impact of COVID and what it means right now for them to have vaccines, and how our community is responding to the vaccine. I just wanted to share that as a Latino woman and a registered nurse, there aren't a lot of nurses, believe it or not, in the bedside who are Latino in a lot of institutions. We have a very large community, Hispanic, and many women of color in this community. But what we do share in the community is cultural and a lot of religious beliefs, and a lot of old stories. When it comes to the vaccine, many of the conversations with patients that I have had to encounter who were coming in for various reasons, some were here to visit relatives, others for treatment, some for COVID testing. Often I do COVID testing now, and I do vaccines as well. Those who came in for COVID testing would stop to ask about, the COVID vaccine. The presentation just before mine was excellent because a lot of the issues were discussed. But on a cultural note, I just wanted to bring up what were some of the issues related to the fears. Oftentimes, many of our community had great fear of vaccination because of religious issues and beliefs. Some were issues where biblically they've talked about the end times and what that means. Suspicion on an issue of politics, suspicions about the DNA or the RNA being manipulated, and who is getting that vaccine? Are we a testing vesicle, right? Because that goes back in history where many folk were tested on without consent. And so there was a lot of suspicion on a political level, on a cultural level, and on a religious level. A lot of our community really were afraid to become somebody's experiment. And they were very afraid about moving forward and having this vaccine. And then later on, because you see, they said it's experimental. And this experimental medication is supposed to help us, but the question in the community has been helping who? And how are they helping? And what's going to show up 10 years down the line that we are all at this moment celebrating? So these are many of the common fears that have been brought up in discussion. I have to tell you that while I'm a registered nurse, a lot of our colleagues in the beginning had the same trepidation. The healthcare workers who were healthcare workers of color and have pretty much a lot of the same, backgrounds. They had, many of their families had faith-based issues, which discouraged their colleagues or their family members to go ahead and vaccinate. Some people had the issues of, being a person who was experimenting. Now, this is very hard for, your culture and your religious beliefs are something that you bring into what you do for a living. Oftentimes, it just pours over and you don't realize that your personal beliefs are there. As healthcare workers, we have to re-educate ourselves, reaffirm what we learn in science and how to educate our patients, and then make that personal, hard decision Do I call my mom and tell her that I'm not going to have this vaccine, or that I am going to have the vaccine? I work with a colleague of mine who spoke to her medical doctor, and she was given the reasons why she should. She finally gave in and went and had her vaccine. And then after she had her vaccine, by the way, that I gave to her, she said to me, "I'm not calling my mom. She's going to kill me." Why? Because her mother had a lot of cultural, religious trepidation.
Mm-hmm.
This is a registered nurse about this medication.
And Sandra,
I had a lot of,
I would like you to share more of your personal story, but because you're mentioning faith and cultural, I forgot how you framed it, but the cultural beliefs and the faith, I'm going to transition to Reverend Jacobs. But I do want you to share some of your personal story with us in a few moments. Not doctor, I apologize. There's so many doctors here right now. Reverend Jacobs was ordained in 1992 at the Cathedral of St. John the Divine, where he served for 12 and a half years and has been in ministry for 29 years. He was former chaplain at Roosevelt Hospital, now Mount Sinai West, for 7 years. He's currently on the staff of the Episcopal Church of the Holy Apostles on 28th Street and 9th Avenue, which is the largest soup kitchen in New York City and the second largest in the country. Reverend Jacobs retired from banking in 2011 with over 40 years of experience, including as vice president and district manager overseeing branches at Commerce and TD Bank in Manhattan. He's also worked at several other banks. Again, we have an incredible panelists here today, and I'm cutting all their bios really brief, making it really brief. Thank you for being here, Reverend. If you could just talk for a few minutes, your perspective.
Thank you for inviting me. I want to keep it more on a local level.
Yes.
At Holy Apostles, I mean, the COVID has taken a toll on everyone in the community, not only in the community, but in the city of New York. And what we have done at Holy Apostles, where we had as you just indicated, we have the largest soup kitchen in New York City, where prior to COVID, we were serving approximately 3,000 meals a week. Because of COVID, that number has significantly increased, whereby we have not only the soup kitchen program, we have a backpack program, a pantry program, and when you total everything up per week, our numbers are now totaling 35,000 meals per week. So it shows the impact that the COVID has had, where people have lost their jobs. And what we're trying to do is to provide food for those individuals and their families so that they can continue on until such time as they're able to go back to work possibly and feed their families. Now, I've had concerns about why Black and brown communities are not taking the vaccine, or had some trepidation about taking the vaccine. I, for one, couldn't wait to get mine. And my wife and I were fully vaccinated back in the middle of February. So the experience is, this has caused an experience of social isolation. Churches aren't open for the most part, although we are starting to open those places. And we're going to abide by the CDC rules when we do open. But I have to question, where is one's faith in this thing? As disciples of Christ, he was a healer. This is an evil that's come out, this coronavirus. And what did the disciples do? The disciples went out and spread the good news. The good news today is that we have a vaccine. We have several vaccines. And there's no reason why we should not have our faith that these vaccines are good. I mean, we had the former presidents on TV show, or public show, that they were taking the vaccines. Of course, the last one took it in hiding, but it's there. Why not use it? Why not take that vaccine and safeguard yourself? You've been socially isolated for a time being, and this will allow you now to go back out, reach your families, friends, and you wouldn't want to be the one, because you didn't take the vaccine, to spread the virus out there. Scientists and doctors are saying we need to have 70 to 80% herd immunity before we can say take off the mask and things like that. So it's incumbent upon all of us to take the vaccine, get the vaccine into our arms, and see what we can do in terms of controlling the virus. I've been hearing what the doctors have been saying today, and it's good to hear what's going on globally or in this country. But we have to concentrate also on what's going on in the community right here. And what Holy Apostles is trying to do, we're trying to provide for that community the best way we can. We talk to some of the people who come to make themselves available for food, and they complain about having a hard time getting appointments and things like that. And through what we do, we tell them through perseverance, continue to try to get the appointment for your vaccine. New York is lowering the age now to 50, so perhaps that will increase the percentage of Blacks and Brown getting that vaccine. When you see pictures of what's going on in Florida, and then these people then come back and infect others, that is not good. So my thing is, get the people to get the vaccine. We will continue to provide food for those people out there in the community. We find people not only serving in the community of Chelsea, but we're also finding them coming from all the boroughs. They know about Holy Apostles. And so we invite them to come to us. We'll provide other social services for them. And that's about it.
Thank you. Thank you, Reverend Jacobs. Being mindful of time, I see it as 7:21, and I know Dr. Fullilove has to teach a class. I'm just going to pause here to give you some space to share if you have any last thoughts that you would like to share based on what you've heard, or ask Katie or Vera, and if they have any questions. I have a question, but I want to hear what you have to say before I jump in with my curiosity.
Maybe the most useful thing I can say is that, number one, I'm 77 years old.
You look 50.
Well, thank you. I actually set it up so that people tell me that all the time. Please forgive me. It's a flight of ego for which I ought to be punished, but I've been vaccinated. I'm very clear that at this point, it's been more than a month. I had no ill effects, had no side effects. I've been tested 3 times because I'm at Columbia University's medical center. So I'm in and out of places where the possibility of exposure exists. And I think it's important to understand that we spend a lot of time worrying about those who are vaccine hesitant. My experience has been that there are a lot more people trying to get the vaccine and are struggling to find places where they can access it easily. That much of what is hurting us, especially for folk who are my age, is the digital divide. You've got to have a smartphone. You've got to have connection to the internet. So much of this is being mediated by what's happening in cyberspace. That which keeps us from that technology is also keeping us, in too many instances, from taking advantage of many of the services, and certainly the vaccine, which I think has the potential to save lives. Having gone through this and having seen that not only are there no ill effects, but I continue to believe that the data demonstrate that even the vaccines that have just recently shown up, the one from Johnson & Johnson, all of them seem to make it clear that the likelihood that you'll get a severe form of COVID-19, the likelihood that you'll be hospitalized has been dramatically reduced. So as Reverend said just a few seconds ago, it's in our best interest to do this. What I worry about most is that our fear, the notion that people have started to believe the conspiracy theories, would mean that when there's something that could have dramatically improved our health, that could have prevented so much morbidity and mortality from hitting us, because we didn't believe it and because we didn't trust it, we failed to take advantage of something that could have been absolutely essential for keeping us and our neighbors safe. So my hope is that myself, having believed that this is something that is really going to work, others will agree that the real issue is not so much to convince the doubters, it's to make sure that those who wish to be vaccinated will have easy access to it, because I think it does have the potential to dramatically turn much of this pandemic around. How about I stop there?
Okay, great. Thank you. Viren or Katie? Oh, I see a little person. All right, I'm going to jump in with my question then, Dr. Fullilove. I'll let you go first, but it's also for Dr. Shepard and whoever else wants to answer. But I'm just trying to engage you a little bit. I see you have about 5 minutes left. And I don't know if you can answer, but I'm wondering about maternal mortality and hesitancy to get the vaccine, and if there's any overlap or crossover. Yeah, I'll leave it, my question there.
Yeah. So, did you want to address that?
Wait, Dr. Shepard, let Dr. Fullilove just say a few words.
Yeah, sure.
Yeah, just that I think it's very important that people who are concerned about this look at some of the web pages that have been produced by the Centers for Disease Control, and in some instances, the New York State Department of Health. What are you going to discover? That there simply have been no fatalities or serious health impacts that are associated with the vaccine. Now, a lot of people who have gotten it who are very aged may die, but part of what happens is we're not linking that death, the death of somebody who's aged, with something that's related to the vaccine. So I think the people who are worried about its safety every single day, as we have more and more millions of Americans vaccinated, the evidence that indicates that it's safe, even for those who are in the midst of a pregnancy, should be taken seriously. And I think that if you're in a setting where you're very likely to be exposed, this is the kind of addition to your health and to your health behavior that can often make a really important and significant difference. So I think that people are okay with having doubts, but there are all kinds of ways you can test whether or not, in data that is released by the Centers for Disease Control, there are reasons to worry. If you're seeing, as I do, that side effects are not really a part of the vaccination campaign, maybe you'll feel safe, maybe you'll feel authorized to go do something that can protect you and the newborn. And I've got to go, folks. I've got to set up my class. Thank you so much. I appreciate the opportunity to be here.
Thank you so much for being here.
Thank you.
Dr. Shepard.
Yeah, right here. So as a board certified OBGYN, this is something that comes up very often, is how this might impact me as a pregnant woman and my unborn child. And many people are hesitant, which is rightedly so. But if you think of where we've advanced with science and technology, if you think of even polio, which has pretty much been eradicated, we have done so much research when it comes to vaccine. I think that people believe that vaccines, for this one specifically, was because it was emergency, that it didn't go through all the trials that it should have in order for it to be heralded as safe, which quite actually, on the contrast, it has been studied. They even use this technology as far as the mRNA during Ebola. And because there really was no severe outbreak like you saw here in the pandemic, there was no need to necessarily come up with a vaccine. And so they use that same technology in order to come up with this vaccine. And, you know, scientists and virologists, what they do all day, every day, is figuring out what is coming up, how can they combat it, how can it impact humans, and what next steps they would take. Now, coming back to pregnancy, obviously through a trial, when they were doing the trials of Moderna and Pfizer, they didn't have pregnant women in the studies, but inadvertently you'll have people who were in those studies who got pregnant, who didn't know they were pregnant and got the vaccine, or got pregnant shortly thereafter. And just like we were saying earlier, is you really want to look at their outcome and what that really looked like. What we were able to say with certainty is that we know for sure that what we're really looking for in vaccine coverage is not so much that you don't get the disease, right? It's more so if you do still happen to be have exposure to it, or if you were still to get the disease, are we going to decrease the mortality rate? And what we were seeing prior to the vaccine is that people were dying in rapid numbers, in high numbers globally. And so, the responsibility at that point is to decrease those numbers, or if you do become ill with COVID, the severity of the disease is not as impactful because we were seeing ICUs being taken over. We were really seeing a decrease in the utilization of resources and physicians and healthcare providers because there was just so many people. It was an overload. So that really is when you look at a vaccine coverage, you're really looking to see, can we decrease the amount of people who are dying, or if they do get the disease, can we decrease the severity of the disease? And we know that it's much more infectious than flu, and people like to compare it with flu, but you really can't compare those two because they're two different viruses, but the rate of death is much higher what we were seeing in COVID-19. So that is kind of hopefully some helpful insight for people who are still considering if they should get it or not. I know there's a question in the chat about the use of fetal cells for the actual vaccine. And that really goes back to historically how they use a medium in order to grow a vaccine that can be used for future. So it's not currently, they do not use current fetal cells in order to grow a vaccine and to test it. It really are the cell lines that were used from literally decades ago from fibroblast cells, and then using that medium to continue to grow vaccine cells. So it's not from live terminations or aborted fetuses. And I know that's a question too. So I hope that is reassuring when people are really thinking about if they should get the vaccine. But as a physician, evidence-based medicine is everything to me. And I know that the outcomes are we're decreasing the transmission and we're decreasing death.
Okay, good. Thank you. I want to move back to the two presenters that we have left, Laureen Valentin and Charlene Koloki. Laureen is currently the Manhattan Borough Outreach Director of Test and Trace for NYC, for New York City Health and Hospitals. She's a young professional Latinx woman who was born and raised in East Harlem and the South Bronx. She has over 10 years experience in healthcare and political campaigning. Before Test and Trace, she was the National Executive Director of a national multicultural sorority. Laureen, thanks for being here. And if you could just share for a few minutes before we go on to Charlene.
Sure. First of all, I want to say thank you to everyone here for having me. I feel super honored to be on such a high quality panel. I feel unworthy of being here. So thank you all. Maria and Jesse especially, but I guess they asked me, I know they had reached out to me initially when they first started doing the planning for this specific meeting about a month ago, and asked me to join because they heard my personal story about vaccine hesitation. So I have been working for the New York City Health and Hospitals Test and Trace for 5 months. Now, as the Manhattan Borough Outreach Director, I work in high positive zones of COVID-19 all over the borough of Manhattan. I started first in the borough of the Bronx, and I assist in Queens and Brooklyn as well. All borough directors do. However, I would have to say when it first came out about, we finally have the vaccine here. So the work is going to be 50% testing. That was our priority for New York City Health and Hospitals Test and Trace, and then eventually flow into 50% vaccination. A few of my colleagues, all of the borough directors are persons of color, first and foremost. And so we discussed amongst ourselves how we felt about that, being on the front lines in communities of color, in equity zip codes, where we're trying to increase testing and make sure folks have access to testing, not just in the hospitals, but actually, in their facilities, bringing mobile test units to their communities. And so, folks asked us, have you gotten tested? How often? And so we know the question was going to be, have you been vaccinated? Are you going to get the vaccine? And we weren't sure. I know specifically, I said I wasn't sure. I had an underlying condition. I have a pre-existing condition. I have endometriosis. I was diagnosed with stage 2 5 years ago, which means that my fertility rates are lesser than most women. And I wasn't sure about taking the vaccine as, one day I hope to have children. Aside from that, I have other, have asthma, other pre-existing conditions. At the time, I lived in a multi-generational home with my mother, who's a nitro worker. And I also helped to care for my grandmother who has dementia. So I was really nervous, but I also knew that being a leader in the community means that you really have to put your foot forward. And so it took a conversation with my colleague, who happens to be a West African Black man, to sit down and really go at it. We had a discussion, and he had me about 85% convinced, and I do presentations all the time for the city of New York for test and trace. And, I already had all the information on vaccination. And I think for me it was two things. One, knowing that Dr. Corbett, who happened to be a young Black woman, 35 years old, who worked for the Vaccine Research Center, she cracked the code for COVID-19. So there was a woman of color. And then before I tell you my second that hit it on the nail for me, I want to let you know that I have an aunt who was born and raised in Puerto Rico, came here with my grandmother, who's barren because of the birth control trials that they did in Puerto Rico in the 1950s. And then I have an uncle who's a US veteran who also was never able to have children because of Agent Orange. And so those two things really impacted me, because they're not just like relatives outside. I see them all the time. They're still very much part of my life. And so that really, really did play an impact on my vaccine hesitation. Although I'm a leader in the community, this is my job as a director, it's not mandated for us to take the vaccine, but it was an option on the table. And then my mother caught COVID. And it was the scariest moment of my life. I had already been working in high positivity zip codes and all over New York City. And I was afraid that I gave it to her, that I brought it home from doing an outreach event one day. And it wasn't that, she happens to work for NYCHA in the Bronx, and somebody came to work sick and they didn't say anything. And they didn't get tested until it was too late. And then my mom got sick, and I have two nephews. We live in a multi-generational home. And so one of my nephews is autistic, and he has 18 allergies, and he's 5 years old. And so the scariest moment was we were in the house when she got the result, and my nephew was literally in front of her. And, how do you tell a baby to get away from you, that you don't want to kiss them or hug them, especially when they're special needs? And, it dramatically changed our whole household. We had been careful, had been very vigilant. In fact, we've got into a lot of arguments of my family because I work for Test and Trace, and I was very much OCD with how we disinfect when we come in and out the house, how the kids are around, why I wanted everyone to wear masks in the house. And, I got overrun, so I usually stayed in the basement most of my days, especially when I was out doing outreach events. But that for me hit it on the nail. And so when the option was available for folks like myself who are on high positivity rates to get vaccinated, everyone was really shocked when I did. And I did it at Lincoln Hospital in the South Bronx. I got the Moderna vaccine. I also do mutual aid in the Bronx as well. I'm still very much affiliated with the National Sorority. So in doing so, not only did I breach conversations with folks from elder generation, but also folks, millennials, who were very hesitant, who were very knee deep involved in these conspiracy theories. And so it's going to take yes, we do need to bridge the gap between access to vaccination, but there also still is this very large portion of our community and population who have lost their faith, who have lost their belief in even science. And I myself, who I feel like I'm pretty knowledgeable and I'm an avid reader, I definitely let that fear get in the way of being able to get vaccinated sooner rather than later, just because there were so many unknowns and I wasn't sure what was going to work out best for my personal health and our needs. But I definitely decided to jump the gun as soon as I was finally available to do so and ready mentally, and it was the best decision I could have made for myself at that moment. And I can absolutely say that after that, I've had many discussions with folks of women, especially women of color, way younger than myself in their 20s, who have had a real vaccination hesitation because of fertility issues, because they want to have kids and we don't know what's going to happen, after the vaccine at that time, after the vaccine had came out. So I was really happy to be able to do so. And I'm still happy to be here and to talk about these things, but these conversations are hard to have, especially in certain rooms, but they still need to continue happening.
Yes, thank you so much for sharing, Laureen. And actually, that's why I invited you here, because I thought your story was powerful. Sandra's also, but just before we go into the questions, and at that time, I'd like to have Sandra share some of her story. I'd like for Charlene to speak. Charlene Kaloki is the Community Relations and AmeriCorps. I know I'm mispronouncing it. Charlene, help me out.
AmeriCorps.
Thank you. AmeriCorps Program Coordinator at Ryan Chelsea Plain Community Health Center. Charlene has experience with community engagement and health education as an AmeriCorps service member and over 9 years of community volunteering experience. Charlene has an educational background in public health sciences and is currently enrolled in a Master of Science program at the CUNY Graduate School of Public Health and Health Policy. And she plans to continue her work in the field, completing her degree in health communication for social change. And I believe, Charlene, you're in the first graduating class, correct?
Yeah. Yes.
This program, which is awesome. So if you could briefly share some information, that we discussed you'd be sharing tonight.
Yeah, sure. Jesse.
Hold on, sorry.
Thank you, Jesse.
Give me a second.
Yeah, no worries. I was just going to say, first and foremost, I'm extremely honored to be a part of this panel. I actually did see Dr. Fullilove give a speech at Columbia, I believe it was a year or two ago, on 400 years of inequality. And that continued to ignite my passion in public health. So it's really amazing to come full circle and be on the same panel. And Jesse, I think it is.
Sorry, you just muted yourself, Charlene.
Oh, I was saying it's not this this slide deck, it's the other slide.
Sorry, I thought we were picking up from where we left off. I apologize.
No.
Okay.
Yeah.
Everybody give me one more moment. My apologies.
I can let Dr. Fullilove know that, Charlene. That's amazing.
Yeah.
Let him know yourself. I think that's really awesome.
Yeah. So I was amazed, to be invited to speak alongside him. And some of the stuff in the presentation actually echoes quite a bit of work that he's done and published. So I'll give a brief overview, but by all means.
You can start the presentation before the slides come up. It's fine.
Yeah, give me a second, Charlene. I'm sorry, my system is mixing up the two. So
it's okay. Charlene knows it by heart, but Charlene, you're on mute.
I'm not sure why it keeps muting me because I didn't push mute. So I'll go ahead and just jump right in. So part of what I was going to speak today about was vaccine hesitancy, the importance of keeping things in context and understanding the history behind why it is that we got to where we are right now. So as echoed earlier, Dr. Shepard said this, Dr. Fullilove, and Laureen also just mentioned this as well. The focus isn't necessarily just on how to convince people to do a certain thing. It's about how can we look at what's happened in the past and learn from it, and also make sure that we are include, oh, okay, there it goes. Okay, you can go to the next slide. And then you might have to hit, perfect, yeah. And reasons why it is really, really important to have reliable, trusted resources that are available to people, and also too, that is coming from people that we trust. So as mentioned earlier, some of the issues and ongoing issues with the pandemic were inadequate access to testing, treatment, disparities in death rates, the fact that the majority of the essential workforce was made up of communities of color, so that predisposed a lot of people to contracting COVID-19. And a lot of that reinforces this notion of you're not necessarily a priority. Your care, your health isn't necessarily of concern or as importance. And personally, as a person of color, and particularly as a Black woman growing up in this country, as a first generation immigrant myself, I have also seen a lot of inequalities happening, have experienced a lot of discrimination, both in the medical field and just outside. And for those reasons, and of course, a lot of the examples that are provided on here, a lot of political and socioeconomic policies that have really driven that narrative home for me, were really difficult to not necessarily look past, but to take it alongside with the research that was coming out around COVID-19 vaccine safety, who was involved in the trials, who was involved in the actual production, and having such a close view and such a close relationship to the field. That part to me was very beneficial in my decision to get vaccinated. And as Laureen just spoke about it as well, right? Like taking community and family into concern. As a person who has a father who's currently living with diabetes, that was always my biggest concern is, would I potentially give this to someone and, them suffer from a much, much worse effects from COVID than myself. And also seeing too, with their interactions with the healthcare system, oftentimes like things that my mother might bring up would be overlooked by providers, and she might not have necessarily gotten the testing that she needed to catch an injury that she had much earlier. So these ongoing issues, even within our own family, was very difficult to acknowledge in the face of having access to the COVID-19 vaccine. But again, like Laureen mentioned, right, a lot of the education is extremely important. It coming from a reliable and trusted source that you have is also extremely important. And also presence in the community and concern about other disparities, not just COVID-19, is extremely important. You can hop to the next slide. So again, with reframing, right? So really important questions to always ask whenever there are community-facing efforts happening is how did we get here? What can be done to resolve the disparities and inequalities? Who should be involved? When can we expect to see changes, not just speaking about it, but actually taking action? Where can these changes be seen and why is it necessary? And next. So some examples of actions that have been taken to start to correct for some of these issues are establishing FQHCs, so federally qualified health centers where people can come and access affordable and quality care. Marlene spoke a little bit about our history. There's also a lot of other FQHCs that are in the city and across the nation. Things like making sure that our providers are there. So increasing access to quality education and resources throughout school, after school, and in general for the entire community. And then another action is community-based participatory research, which really involves community members and what they would like to see and what they would like to learn about things that are going on internally. And they can partner with organizations that can help with funding. And a lot of the research and findings that come out of this can result in direct action. So it's not just a top-down approach of we want to study this for the sake of studying this. It's we want to study this because this is something that impacts us and we want to be part of the change. And next. So some things that we are doing on our part to increase community access to vaccinations are community pop-up clinics. We have evenings and weekends available at our center for COVID vaccinations. There's no barriers whatsoever to getting vaccinated. So if you're eligible, and you may not necessarily have documentation to support that due to your immigration status, there are other alternatives, and we're more than happy to connect anybody who may not have identification and things like that to vaccines. We believe that everybody has a right to access health services. It's free, and as mentioned earlier, it does not cause infertility. And next. So another thing that we've also been doing is community education. So Marlene Taylor, one of our providers who's here on the panel, is providing ongoing community education in different forums. We have a few other providers who are also helping with that effort. And when we do physically go out, myself and a few of my AmeriCorps members, we really focus on the education portion of it and making sure that people actually understand the data that's being presented and know where to find information and where to find resources. Next. So we have in total been able to administer about 4,500 vaccines to date at our site in Ryan Chelsea Clinton. And we're using Moderna and J&J. There's some data there by zip code. We don't have demographics by race since we send all of that directly to New York State. But by zip code and by the people who we partner with, we try to target organizations that do serve marginalized communities. So some that are listed on there: Metro Baptist Church, Metropolitan Community Church, Hudson Guild, Clinton Housing Development. Some future ones that we're looking to have are NYCHA, or with some NYCHA communities, Project Find, Manhattan Community Court, Fifth Ave Presbyterian Church, Midtown South Community Council, NYC Relief, and the Reverend who's also on this panel. We are also looking to partner with Holy Apostles. So definitely looking forward to that. And next. So some places where individuals can access some of the resources that we can assist with and other organizations in the community can assist with are through our Here For You platform. So you can find resources based off of your zip code. And as mentioned earlier, right, technology is still a pretty large barrier for people. So we do have individuals who do contact our patients directly to kind of assess and see what needs they have, and then be able to connect them that way. And next. So in conclusion, we know that disparities will not disappear after the pandemic ends in the general population. We have to ensure that whatever efforts are being made, we're making sure to ask who's being involved, what's the purpose, when can we see the change, where can we see it, why is it important, and how is it being done? So accountability is extremely important, as well as actually taking action and not just speaking about how to stop the cycle of marginalization. Every single person has a part to play. Things that you can do are listening to people's needs, including people in developing plans, engaging communities directly, building partnerships like this amazing panel that's here that has people from across the board. And then, of course, continuing community education and advocacy. And also say, right, like a system that has consistently discriminated against individuals, and we've seen the disparities that have come out of it took so long to build. It's going to require serious work on all of our parts to ensure that we can actually start to see a change for future generations. And last but not least, one thing, an actionable item that you can take if you are somebody who is a licensed healthcare professional, we are looking for people to assist with vaccinations. Like mentioned earlier, there's a huge demand, and it's really hard to meet that with our current staff. So we would love to involve as many people as possible to assist the community.
Great, that was a good plug, Charlene. That was a good opportunity to do this. Thank you so much, Charlene, and everyone who spoke on the panel. I know that we had to lose somebody. Laureen said she had an emergency. She had to jump off. And we're going to transition here. I would like if people from the public could put their questions into the Q&A. And in the meantime, I know that I have one question. Leslie, maybe you have a question, or panelists have a question for each other. My one question, and I was actually speaking to Jesse earlier, and this is how the question came about, but it's something that has come up already. Laureen and Sandra mentioned it to me one-on-one when we were talking about inequalities and reasons for distrust, inequalities in healthcare and the distrust, and thinking about intergenerational stories. And I like the term Jesse used, how it's weaved into people's existence, and thinking about the core, what the core of the problem is, and how do we address the core of it. And it's not just about education, right? And Charlene, I think you just touched on that a little bit. You mentioned FQHC. I'm not sure, I forgot what that stands for. Federally Qualified Health Clinics.
Center.
Health Center. I was close. And you mentioned participatory, something else.
Community-based participatory research. I know it's a mouthful. Yeah. Or they just go by CBPR for short.
It's CBPR. Okay, thank you. And thinking about that, I was curious what other panelists thought about, I guess, my question, that how to get to the root of the issue if it's not just about educating people, for example, about what maternal mortality is, or it's not about just being educated on the validity, I think that's the correct word, of the vaccination. I don't know if that's the right word, but the effectiveness of it. So I'm just wondering about thoughts that panelists might have.
Yeah, so I may have to jump off in like 15, 20 minutes, but I wanted to, I think several of the panelists spoke briefly and mentioned the fact that, and I think the nurse Sandra, when she spoke about her family and growing up, and I think the patient who didn't want to talk to her mom afterwards. I think, you know, what I see on a daily basis, even in the past, having a history of working on treating HIV from the beginning of the epidemic, so many of the similarities I see with COVID in terms of not only what the disease is, how it came to be, why is it disproportionately affecting people of color, like a lot of cultural just mistrust in the healthcare system. And we all know the stories and the facts that have occurred in this country. So even if I give them the facts, I find that I have to go a little deeper with them on a different level, whether it's, for example, in the churches. So with HIV, we found ourselves not only in the clinic and in the hospital trying to get patients to take meds and getting them to understand that they could die if they didn't follow up, but we had to go into the community, into the hair salons, onto the basketball courts, into the churches, and really get into the nitty gritty, the places where they do, where historically, you know, I'll just say it's, as African Americans, where we've gone for hope in times of, you know, in those times in this country where we had nowhere else to go but our churches. And so when we educate patients after church at different, you know, events, we have to meet them where they are. I think that's the big takeaway, and not just stay on one side of the equation and try to talk to them at, you know, at a health fair or something like that. But we have to go into these communities, we have to go into their homes, we have to use examples. I used to have a board in my office when I was on staff at Montefiore, and those patients who agreed to have their stories told or their experiences, they didn't mind having their pictures there. So when I spoke to a new patient about starting on medication, I would refer to those patients and say, oh, they lived on, you know, 145th Street or lived on Taylor Avenue, and make it really personal so that they could try to connect that way. Because
I also, Marlene, I also saw that at the Ryan Center. The pictures that are up on the wall as soon as you enter.
The staff, right? So the AmeriCorps workers really take a lot of time and effort with trying to meet patients where they are and using examples that they can relate to. So as you mentioned, it's not just the education, because then it's, you know, breaking down the terms and then using examples that they can relate to,
Yes.
and hopefully them understanding that. And it takes time. It may not be the first time. It may be the third or fourth time that they come back, but getting them to continually come back and listen and hopefully approach it from that angle.
Yeah, that makes sense. That reminds me of other kinds of social services kinds of work. I'm a social worker, so I understand what you're saying. Reverend Jacobs or Charlene, I don't know if you wanted to respond to that at all.
Well, the churches are open.
Or Sandra, I'm sorry, I don't see Sandra's face, so, and there's someone else here, but I don't know who that is.
At Holy Apostles, we have a justice committee, and they are open to participate with other organizations to get the word out. We have a number of gay parishioners in Holy Apostles, so it would not be difficult to do something. All are welcome at Holy Apostles. We don't turn away anybody because their sexual preferences or race or anything like that. Churches are open, so we'd be glad to help out where we can.
I don't know if anyone else wanted to respond to that.
I could say,
Sandra, go ahead. You were going to say something.
no, I just wanted to add, as we had said previously, working at the bedside and working and vaccinating and COVID testing, I've had to deal with fears from the beginning. And the young lady who spoke previously, who spoke about her personal experience, the cultural issues, the sciences, which is what I was leading to. Oftentimes, that's the conversation that the patients that I would see would have. And they do that not when they see, they don't want to do it in a crowded space. They don't want to do it where, you know, they might think that their thoughts or their emotions are going to be considered silly. They don't want to feel as, you know, they want to be able to feel comfortable in expressing how they feel about, you know, how they grew up culturally. Sometimes I'm with a patient on a one-to-one, getting ready to do a vaccine. And before the question before the vaccine is one that they may have read 50 times or heard on a commercial, or even had a discussion with the doctor. But that cultural, that history, those moments with their parents, sisters, brothers, siblings, they come right there, right before that shot. They'll stop and they go, hold a minute. You know, what do you think? I can't tell you how many patients ask me before they get vaccine. The minute before I'm ready, they've been great. They signed, they're ready. And that last second hesitation. Nurse, did you get the vaccine? How did you feel? What do you think about it? The fear is there, right before that moment. And even that moment is an education. I've had people who want to walk away while they're there. There's this deep-seated fear, and it's about that moment, those opportunities to speak to people. My mother is vaccinated. My husband's vaccinated. My husband got COVID, and we're both healthcare workers, and we were on the front lines when it all started. My mother has dementia and a COPD, multiple comorbidities. And I was asked to help prep people for PPE, getting dressed up. And this was in the time where we really weren't quite sure, you know, what COVID was. How do we protect ourselves? Nurses and doctors were clamoring to put on equipment, and they were being asked, no, we're not quite sure yet. You know, we don't want to offend patients.
I have two questions for you, Sandra. Sandra, two questions for you. But you and your husband were in fact hesitant also.
Yes. Well, no, I was more hesitant.
Okay.
And I was more hesitant than he. And he wasn't quite sure. There's a lot of, in his community, where biracial marriage. In his community, he, you know, there was so much done to him in his life. So he was like, you know, I don't know about this. Let's wait. But get COVID. The saddest part about this whole situation was that I could not see my husband and care for him while I was in hospital caring for members, my colleagues and friends, and I have to choke up on this issue, and patients who were behind screens, dying with no one to tell them they love them, with no one to hold their hands, on respirators, staff dressed up in suits. This was the most scariest time that I could ever tell you. And I was in a hospital caring for other people. And my family member was in isolation by himself, 50 miles away from me, by himself. No one, no family, no friends, anyone, isolated. He had to go through this by himself. The only thing I could do was call him on a phone, because when I left work, I came home to strip off every item of clothes that I had, to throw them in the washing machine, to run to the shower, because I wasn't in my home. In order to be able to work where I was, I had to remain in the city. I was in my mother's home, the most vulnerable member of us all. And I was coming to her house after I finished taking care of patients who the staff was falling from getting COVID, from, because we were still working with what this was. And so I have to say, when this vaccine, you see, we live this experience every day, but we still were hesitant because it wasn't the intellectual part of it. It wasn't the understanding.
It's not the education part.
Yeah, it was that emotional background, that growing up with that suspicion, that religious belief that gave you, that made us kind of, and here we are, healthcare workers with us, and we're still holding back. I'm watching with my own eyes people dying, and I'm in pain and agony for them and their families. And here comes the vaccine. Help is on the way. Help is on the way. And here I am, my heart is still saying, should I take it? Mm-hmm. So my brain is saying, are you kidding me? I'm split on this emotion. Can I tell you how many times I've had this conversation with people who are coming in to have vaccines or be COVID tested? Not too long ago, I was testing a young lady with multiple comorbidities, and she was going to have a procedure.
And then I'm going to ask you my next question after you share this story. No, after you share the story. You have to share the story now. You started.
Yeah, I have to say, well, the young lady, multiple comorbidities. She's coming for a swab because she's going to get a procedure done. And she looked at me and she said to me, did you get the vaccine yet? And I said, yes, I did. And she goes, well, I'm not going to have it. And I looked at her and I said, why? Are you afraid? And she stood for a second and looked at me and said, yes, I'm really afraid.
Yeah.
They did this thing, this RNA. What does that mean? Can they later on change me? This is a young lady. Can they change me? So we have fears about what enters our body, what it can do to us, and what do we think about. And I took a few minutes with her and we talked about what she felt. And actually, by the time she left, she was prepared to go get a vaccine. I'll see her in a couple of weeks. But gotta say this to you. It was not what I said to her, it's what she was able to say to me. In her conversation, Amen. She was able to talk and share her fears. It was just the young lady and myself in a quiet room, one-on-one. There was nobody judging. There was no one to argue. I just wanted to hear her why what was her story, and then let her make up her mind.
And
Of
sometimes,
course.
Sandra, sometimes I think that's really powerful, right? I
Yeah.
think you put it perfectly. It's what she was able to share with you, but she was able to share that with you because you asked the right question. And sometimes it's about asking the right question.
Correct. Yeah.
Speaking of asking the right question, I have another question, less emotional. I wanted to ask you what you thought about, it was in the Q&A, and I just, how do you feel about vaccine passports? I'm not clear what those are, but someone from the community who's also a CB4 member asked panelists what they think about vaccine passports.
Vaccine?
Passports?
Oh, I'm sorry.
I think that's being developed in European countries. There is some talk about it
Thank
here
you, Vera.
in the United States to have this also. Basically, what it would do is help you when you're getting on an airplane or taking a trip to a foreign country. That's basically what it is.
And asking, the question was, what do the panel think about that?
I think it would be good to have. The only thing I'm concerned about is that, you know, somebody out there is going to be knowledgeable enough to create fake passports like that.
Absolutely.
That's my concern. And then you won't know whether or not they'll show that they have they've had the vaccine. That's basically what it is, showing that you've had the vaccine, fully vaccinated.
Mm-hmm.
But you won't know exactly unless there's some kind of code that can be implemented to these vaccine passports. That's the only way I think the government would have to come up with something to ensure that it's accurate and that it's true.
Katie, Viren, and Leslie. I know that.
And Leslie, I think you had a question earlier.
Yes, I have actually, it's a follow-up to the question that was just asked, and the equality issue. Across the world, there are many countries, and even in this country, there are many areas where people don't have access to the vaccine. So by having a vaccine passport, it can create some discriminatory things going forward. So I think that's a concern that some may have. And I was wondering what the panel thought about that. For one, that was my first question. Anybody would like to respond?
Sure. So I guess as somebody who was actually looking to potentially travel back home to Kenya to go and visit back with family and things, that has been a very big question on our end. Granted, like you said earlier, some nations may not necessarily have access to widespread vaccination up until 2022. So we will likely see a lot of inequality in who's allowed to go where and who's allowed to do what. But it's really difficult to know what the effects are going to be right away. Especially too, as you mentioned, right? Like a lot of communities, even here within the United States, may not even have access to large vaccination sites quite yet. And a lot of that is, of course, due to a lot of the ongoing climate change related crises that have happened recently. And then even too, areas where there aren't federally qualified health centers or there aren't pop-up vaccination clinics happening. So I think that it is a great idea, yes, but I think it will be a very large barrier to overcome and continue to reinforce inequality.
And I guess related to that is what impact of the lack of access to vaccination overseas will ultimately have on us in the United States. Because if they're not vaccinated in Rio or in whatever country that they may be coming from, and they come now to the US, and let's say we get herd immunity or not, and there's a variant and something happens, what is our responsibility as a first world nation in order to help the less advantaged.
What I've heard is that, and I don't particularly agree with it, but the president has already said that with the extra vaccine, because with the Moderna, Pfizer, and J&J vaccines, this country will have more than enough vaccines to take care of the people who live here, and that the excess would be sent to foreign countries, but that's not going to happen until probably the end of the year. I would like to see these pharmaceuticals start distributing these vaccines to these countries, these other countries, so that everybody has an equal opportunity to take advantage of receiving the vaccines. I think that's the way the world is going to have to eradicate this thing. You just can't eradicate it by one country having sufficient vaccines to vaccinate its population. It's got to be around the world. So I would like to see all the vaccine companies, all the pharmaceuticals start distributing their vaccines to other countries. Not just because we have maybe the money to pay for these vaccines, but the poorer countries need it also. We have to, we're our brother's keeper. And the way in which we have to show Christ's love, and we have to share those things that we may have with others. And not just wait until, okay, we've done everything we can here, we supplied everything, and all of it, now we can distribute. No, you need to try to distribute it more fairly to people around the world. In particular, those countries where there is poverty and whatnot.
Thank you.
Yeah. And then just to add on to what the Reverend just said, yeah, I think there definitely will be places where COVID-19 is still endemic and potentially might serve as a reservoir. So it is extremely important to make sure that everybody has equal access. Something I was reading about that earlier as well, the donation to other countries. So I believe the US had purchased a surplus amount and was holding on to a percentage just in case we may need to use them as booster shots in a year or so. As we all know, like the research is still ongoing about how long immunity will actually last for post-vaccination. An interesting thing that has come out of that discussion is patenting of the actual formulations of the vaccine and who's allowed to access those, who's allowed to access the actual formulations. There are several nations that would be considered developing nations as well that do have the capacity to mass produce vaccines, and that would obviously increase the world supply. But as the Reverend just mentioned, right, like it is still up to the pharmaceutical companies to decide if they want to keep that patent private or if they would like to share it with the rest of the world. I think it would be beneficial, granted that everything is kind of moving towards globalization anyways. So whatever happens to you somewhere else is definitely affecting someone somewhere else. And just like that super famous quote of, injustice anywhere is a threat to justice anywhere. We have to ensure that there is equal access globally as well as domestically.
I have a follow-up question, if possible, and it's also about access, but this would actually be about very local access. And Charlene, I know you had mentioned earlier that that Ryan Health is reaching out to its patients who may be homebound or may not have internet access to find out what their needs are and if they need help getting a vaccine. But I do, I think we all continue to worry about people who don't have internet access, who may want the vaccine, and how can we as a community help them? Now, I had heard that in other New York communities, there are efforts underway where people are like going out in the community and knocking on doors and asking if they need help. And I'm just wondering if you sort of what you think is a way to meet the needs of people who don't have internet access in our community. And is this something, you know, that we can write to our electeds about, or is this something that you think is needed? Because it is something that we sort of continue to hear about, right? So therefore it would be people who aren't Ryan Health patients, but other patients without internet access.
Can you hear me?
Mm-hmm.
I'm not sure. Oh, okay. This is Marlene.
Oh, hey.
So I'm on my phone now. So
Okay.
So I know one thing that we as our Charlene probably had some listing on one of the slides, but what I know they have done early on, and my patients who are, you know, in the geriatric population who are not computer savvy and tech savvy and may not have a phone working that month or whatever, what Ryan has done is gone to some of the supportive housing buildings and just, you know, given vaccines to them. And many of them, whether it's their comorbid conditions or psychiatric illnesses, we know that they, depending on their medication, they may not be stable enough to even remember if they have an appointment without those supportive staff that they have in place. Many of them may be found wandering the streets, but if they reside in some of these buildings, Ryan was able to go out and give them vaccines. At least there's a number of them, and Charlene probably has detailed names of the different buildings, but that's a great point. I often think I have patients who say, oh, my cousin, you know, is homeless and they live under the bridge and they want to get a vaccine, but they don't have ID. And so there still needs to be so much more work done to try to reach that population who are the, you know, everyday homeless people that we see, and people walk by and you're wondering, like, do they even know what's going on? And so we have, you know, again, in so many ways it mirrors what's happening with the HIV epidemic. I mean, not to say before we look into a lot of, you know, different ways to try to approach this around the world, but we have so much work to do right here in our communities around just reaching those people who are the most vulnerable, but those who are not only, you know, the sickest, but, you know, the mentally ill, as well as those who don't even have a piece of ID, as well as those who are disoriented and substance abuse, and just so many other factors that impact trying to address this really serious pandemic. So, you know, I think that it's challenging, and, you know, with the support of so many services that I've seen, volunteers going out trying to, you know, as you mentioned, knock on the doors and just try to, we do, you know, do phone calls to those patients. But like I said, a lot of them may not have their phone working that month, depending on how much, you know, the money they have. So
yeah,
it's challenging to say the least.
Yeah.
Katie, I see that Chris LeBron, also a CB4 member, has 2 questions in the Q&A. I don't know which one you want to go with first.
Viren, were you going to summarize and ask?
No, I just going to actually add a couple of things. You know, we talked about the vaccine passport. From what I understand, and this is actually from someone who actually uses that. My brother, he's a doctor, and he works with Doctors Without Borders. He travels across the globe. And what is being sort of probably misconstrued is that passport is basically a yellow card that they give you back once you're fully vaccinated. And it has the sort of date and data and whatnot. And I believe it's going to become digital. So if you have taken your second shot, both shots are kind of put on that yellow card. And that's the only thing that you actually need to show when you travel so far, up until now. I don't know if it's going to become, sorry.
Oh, no, I'm sorry.
I think Marlene.
I'm trying to mute.
No,
trying to mute from my phone. I'm so sorry.
No, not to worry. And the second thing that I just want to quickly say is that there is a global vaccine pool called COVAX that kind of works under UN, WHO. And they're supposed to be actually the custodians of moving vaccine around to different parts of the world, particularly to poorer countries. And now I can read out Chris's question. His question is about Hell's Kitchen's demographics. According to 2020 census, Hell's Kitchen has 43.6% minority, nearly 20% Latinos. We have a 1 to 10 poverty rate. We also have a huge chunk of hospitality industry and restaurant industry. What plans, and I think this is a question for Ryan, what plans do we have, do we know about for mobile vaccine locations?
Yes, it does sound like from Marlene and Charlene.
Yeah. Sorry, I was also reading the Q&A question. Yeah, so that's definitely something that we've been looking to address by working with some of our community-based partners. So like the Actors Fund, we've recently also connected with a theater in I believe it was on somewhere in the 40s, between 8th and 7th. And they were actually connected to a lot of people who worked in the entertainment industry and Broadway as well, who may not necessarily have had vaccine access. So there's them. There's also Breaking Ground, who we've worked with, which mostly does a lot of outreach to street homeless individuals. So we've actually been able to get a lot of people vaccinated that way. And then also to just having some sort of statement saying that they are affiliated with that program was actually enough for them to be able to get vaccinated through us. We're also working, like I mentioned, God of Riverside and a few of the churches in the area. I think the next phase of our outreach is now going to be it's going to be targeted more towards businesses in our area. So what we've been trying to cover right now are the most vulnerable people. So people who are living in facilities with, a large amount of people, or people who are like street homeless and are constantly exposed to whoever is outside and around them. I do believe that there are a few restaurants that are located near Ryan Chelsea Clinton, and we have offered vaccines to them as well. But
Charlene, Charlene, you guys, yes. Ryan Center does have a van, but yes. I don't remember if you actually gave vaccines from the van or not in this community.
No. So in these efforts, we've been physically sending out our nursing teams to the locations to vaccinate people, as opposed to having the mobile van present. Mm-hmm. I think for businesses and restaurants in the area, we'll have to strategize a bit more. I'll take it back to our team and see, I guess, the best way of trying to set up pop-ups would look like. And I'll also put my contact information here in the chat in case anybody wants to reach out directly to me to coordinate a vaccine effort in their area or with their organization.
Okay. Thanks. And I know you guys are going to Harborview soon.
Yes.
You've been at the Hudson Guild.
Yes.
Some supportive housing sites.
Yeah. Okay. And then we're also looking to start going out with Midtown Community Court. They do outreach, I believe, on Mondays, Wednesdays, and Fridays. And we're going to try to pair our vaccine outreach efforts with them.
Can I ask a related question in that we're in the community that has the theater districts and all of these restaurants. Once the businesses start to open up again, and this goes back to the travel issue, and people coming from overseas come to New York and stay and use our hotels, our facilities, our theaters, that could present a problem for our community in particular, because we are that kind of community. Have you thought about going, as we discussed, to maybe those areas and the hotels or the theaters in the future, planning for the future when this hopefully opens up properly to assist in those areas.
Yeah,
So,
definitely.
I mean,
Oh,
yeah.
go-
Charlene and Marlene, whoever
Yeah.
answered.
Okay.
Wait, who?
Go ahead, Marlene.
You have 30
Charlene does
seconds.
have- Charlene does have, I'm more of an in-house with my patients in the clinic staff person, and Charlene has the vast knowledge of what happens outside the doors, even though I hear from my patients, whether they spread the word about what we have access to at Ryan. But what I was going to mention when it comes to the future is we would hope that there are systems in place similar to now where temperatures are taken, history. I mean, just coming into the clinic, of course, we have the questions that need to be asked about travel history and clinical symptoms. And we actually, have a thermometer that takes the wrist temperature when they come in to the center, and anywhere from clinics to going to where was I the other day? And it was something I'm like, what? Oh, of course, restaurants. So we would hope that those type of systems are in place, especially in those places where the volume of people, and of course, this is all in real time, right? So we're making and developing protocols based on the data. And so if the data shows, like the zip codes, for example, where there continues to be a higher prevalence of COVID based on testing, et cetera, data, then I can imagine that in those places there would be stricter guidelines regarding what you do upon having people come into that, whether it's a school, whether it's a church, whether it's, hotels. So based on the data for that area, I know that, things would be adjusted based on what's happening in that particular area.
Great.
So I
That's
think
super
we're
helpful.
developing it. Yeah.
Thank you.
Sure.
And in fact, I'm super mindful of the time, and we're so grateful to all of our speakers this evening who have given so much of your time and have really helped us, I think, have a better understanding of what the issues are and how to frame them and how to, frankly, to reassure our community. And this has given us some ideas too about sort of how we can, move forward and how we can be helpful. Charlene, I love what you said earlier about how everybody has a role to play, right? Whether it's, as a community member who wants to help, as a faith leader, as part of the medical profession. And thank you for sharing all of your stories tonight, because I do think that helps reassure and just make sure that we are all pulling together to deal with this. As we mentioned at the beginning of this call, one of the things that we on a community board do is that we try and identify those issues where we can follow up with our electeds. And I think this has definitely given us some food for thought for our task force. So we appreciate it. And actually, Jesse, if you still have a chance, can you put up just the page that has the website info for people who do have email access? And this is just a bunch of websites about where people can try and find vaccine information. And we'll also put this on our website. But we recognize that not everybody has access to the internet. So again, thank you all so much for participating this evening and for sharing your stories with us. And please continue to reach out to the community board and let us know how we can support our community on addressing these issues. Okay, so thank you so much. And with that, we will close our presentation this evening. Thanks, everyone.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.
Hey, Maria. Good night.
Good night. I'm logging off now.
Good night, everybody.
Good night, Jesse.
Good night, Jesse. Thank you.